CME Outfitters. I'd like to welcome you and thank you for joining us for today's educational activity entitled Managing the Patient with IBD Throughout Life, Best Practices in Transitional Care. Today's program is being supported by educational grants from AbbVie Inc., Janssen Biotech Inc., administered by Janssen Scientific Affairs LLC, and Takeda Pharmaceuticals USA Inc. Today's activity is brought to you by CME Outfitters, an award-winning jointly accredited provider of continuing education for clinicians worldwide. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. That's again, at CME Outfitters. We'll be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using an enhanced platform today that allows you to save slides, take notes on slides, answer your polling questions, and send us your questions. So please take a look at those tabs on the left-hand side of your screen and give us feedback on the program and the platform as well. As mentioned, I'm Miguel Reguero. I'm the chair of Digestive Disease and Surgery Institute and chair of GI, Hepatology, and Nutrition at Cleveland Clinic in Cleveland, Ohio. And let me first welcome and introduce you to my colleague, Dr. Jennifer Dotson. Jennifer is co-director for the Center for Pediatric and Adolescent Inflammatory Bowel Disease and associate professor of clinical pediatrics in the Division of Gastroenterology, Hepatology, and Nutrition at The Ohio State University College of Medicine, and is principal investigator, Center for Child Health Equity and Outcomes Research at the Abigail Wexner Research Institute at Nationwide Children's Hospital in Columbus. Jen, welcome today, and thanks for joining us.
Thanks. Glad to be here, and thanks everyone for joining.
And I'd also like to welcome my colleague at Cleveland Clinic, Dr. Jessica Philpott. Jessica is one of our staff members in the Center for Inflammatory Bowel Diseases in the Department of Gastroenterology, Hepatology, and Nutrition at Cleveland Clinic in Cleveland, Ohio. Jessica, welcome. I know you're only down the hall, but welcome again and good to see you.
Well, hi, Miguel and Jen. I'm really looking forward to this discussion.
All right, so let's go ahead and get started. Let me now review our learning objectives. Our first learning objective is to initiate multidisciplinary collaboration to provide optimal care for children and adolescents as they transition to adult care. Our second learning objective is to implement strategies to address disparities in care in patients with inflammatory bowel diseases by establishing trust, providing education, and engaging in shared decision-making. So before we move into the data and some of our discussion, I'd like to get our audience involved at this time. You will see the question on your screen, and you can choose from the response below, and please go ahead and do this now. Population demographics of IBD in the United States are changing. Which population group is showing an increase in incidence of IBD? A, Hispanic, B, African American or Black, C, Asian, D, all of the above, or E, I'm not sure. So go ahead and vote now, and we'll take a look at the poll. And then Jen and Jessica, I'll kind of get your feedback as well when the responses come up. And as a reminder to the audience, as we go through the talks, feel free to ask questions along the way. So the answer, the 38% said all of the above, 26% said they're not sure, 16% Hispanic, 9% African-American, 12% Asian. And it's interesting, in our pre-poll, there was a higher percent, 31% had said Hispanic. So Jessica, kind of what are your thoughts? What are you seeing in Cleveland? What are we seeing across the country in terms of demographics? And what do you think about these responses?
Well, I think, the incidence, as we know, is highest in white patients. We're seeing a more dramatic increase in these populations. And I think it's important because we really want to keep our eyes out and make sure we're diagnosing it early.
Yeah, and I think now in a second, Jen, I'm going to transition to you, but the only comment that I wanted to make also is, the highest percentage of the responders on the poll said all of the above. And Jessica, to your comment, that's essentially true. We're seeing this now across different demographics, different races. So this is something where IBD is really affecting all patients, all people. And Jen, as I transition to you, are you seeing the same thing in your pediatric patients?
Yeah, exactly. We're certainly seeing an increased incidence across changing demographics, as we're seeing the demographics change as well in the United States. So we certainly see an increased incidence in Black patients. We particularly also have a higher percentage of Somali patients in Columbus, Ohio as well. So we certainly see that uptick as well.
Great. So let's start to review some of the data, and we'll show you some of the PowerPoints here. And so Jen, go ahead. You kind of gave a nice overview. Tell us
Sure.
about the changing population and demographics in IBD.
Right. So as Jessica noted, we typically think of inflammatory bowel disease as traditionally being viewed of affecting patients that have Western or Northern European ancestry. And we've certainly seen this increasing incidence of IBD across the country that we've been seeing that's increasing, that's in the non-white populations. And that reflects our changing demographics that we're seeing in the United States. We also see increased incidence of patients that are being diagnosed that are, second and third generation immigrants as well, which is also a nod to our, environment and dietary changes and more of the westernized culture. So as Jessica also mentioned, it's important that we really understand this changing demographic and that we're in tune to this and that we're looking for this across different populations and demographics that we see in practice, and to really make sure that we're honing in on this and not having our own biases impact any delays in assessment or access to care.
Great. So Jen, now let's look at a patient case. And I think this is a case of a child with IBD. And then maybe you can kind of tell us about the case. And this I think nicely ties into now not only the transition of care, but disparity care as well. So tell us a little bit about this case, this patient.
Yeah, absolutely. So Timothy here represents a fairly standard, patient that we would see in our pediatric GI practice. So he's around age 12. So we typically see this increased presentation in our teenage population. This is when they typically present. And he's an African-American male. And he was referred by his pediatrician to our office for evaluation of abdominal pain and this intermittent diarrhea that he's been having for 2 months. Interestingly, when you actually look at his growth chart, which is something that is tremendously important on the pediatric side, so we always look at our growth charts, and you actually see a plateau. So he hasn't really lost weight, but just really hasn't been gaining and following those growth curves that we typically would expect for a kid his age. And his mother also noted that he's been a picky eater his whole life. And so perhaps that was something that also led to some of the delay in seeing us, is that maybe some of the concerns with the growth chart might have been initially chalked up to, oh, he's just a picky eater and having some belly aches and that sort of thing. And as with, many of our kids, especially when they get into those teenage years, they're usually pretty reluctant, especially the boys, it seems like more often than the girls, to discuss their GI symptoms. They're embarrassing. They really don't want to talk about their poops. So a lot of them don't look at their poop. And when you ask them that, if they've had blood in their stool, things like that, so usually you get no response or minimal response from that. So sometimes the reporting of symptoms from the patient, they're embarrassed. They don't like to talk about it with their providers. They also sometimes won't even bring it up with their parents. And so sometimes it's a little bit elusive getting at those symptoms. And for the case of Timothy here, his pediatrician did some screening labs, and he did have anemia. And so oftentimes we'll see a microcytic anemia, most likely representing iron deficiency anemia from that chronic blood loss, and then a mildly elevated sed rate as well for him.
Great. So actually, Jen, before we go on, there's some great questions that are coming in from the audience. So again, we'll try to get to as many as we can. But one of the questions that came in is how much do processed foods play a role potentially in this increasing incidence and prevalence of IBD? And you could add in younger patients, but also in different demographics, maybe changing from what Jessica said from the white population.
Right. And I think that's something that can potentially be reflected with that westernized, diet and diet habits that we have, and that we particularly see that, like I mentioned, in particularly like those immigrant populations with the changing diet in that second, third generation. And so some studies have linked to, changes in microbiome and changes with some of the, preservatives and overprocessed foods, the emulsifiers, those additives to various products that potentially change the gut flora and more of a pro-inflammatory type of response. So that certainly can be a link of presentation and that we are seeing in pediatrics as well as on the adult side.
Yeah, and so we might get into more diet, but there was a question that just as you were answering that is, are there particular diets that you've noticed that increased or lend to the risk of IBD? And I think just to recap what you said, processed food, emulsifiers, there's also been a lot of research, as you alluded to, on the microbiome, but probably in the carbohydrate-rich diets being potentially pro-inflammatory, and especially with added sugars as well. So I think, unfortunately, what a lot of us like to eat isn't healthy for us, and maybe this is why we're also seeing an increase in IBD in general. So let's go back to the actual questions now. Actually, I'm going to switch gears, and Jessica, when we come out of this, I'm going to ask you your thoughts on this. So for the audience, go ahead and answer now. What would be your working diagnosis for Timothy? A, Crohn's disease, B, ulcerative colitis, C, celiac disease, D, infectious process, E, irritable bowel syndrome, and F, I'm not sure. So Jessica, when we get the answers, I'm going to ask you again kind of what your thoughts are. I think Jen did a nice job at presenting this 12-year-old who had symptoms, but also had some laboratory findings. All right, so what did the audience say? So 46% of patients said irritable bowel syndrome, 16% said Crohn's, 11% said ulcerative colitis, and always a popular answer, 16% said, I'm not sure, teach me. So Jessica, actually the majority of the audience said irritable bowel syndrome. So what's your thoughts on that?
Well, I think what's important in children like this is, as we know, irritable bowel syndrome is not a destructive process, and I don't expect to see lab abnormalities or weight loss. So, and in children like that, growth curve, as Jennifer was talking about, is so critical. So if a child's falling off the growth curve and then he's anemic, I think immediately we have to look into some inflammatory process. So I think those two things alone, I know I need to not treat him empirically. I need to look into this.
Yeah, so I think that could this be irritable bowel? He's a picky eater. He's falling off the growth curve. But to your point, there are some flags, right? He's anemic, which in a 12-year-old boy would be pretty unusual, and showing some inflammatory markers. So Jen, let's go ahead on with the case. And what did you do next with our patient?
So for Timothy, we did proceed with endoscopy. So we will typically do an upper endoscopy, and that showed some scattered ulcerations in his duodenum. And then his colonoscopy, he did have some erythematous and ulcerated mucosa. It was also friable, mainly located in the terminal ileum and cecum, which also tends to be a hotspot in the typical diagnosis that we'll see as far as the disease distribution in pediatric Crohn's disease. Interestingly, when we did his perianal exam at time of endoscopy, he did have a skin tag and a small fistulous opening. And there was just a little bit of scant sort of drainage there. And so this is not an uncommon finding, particularly, with our teenage patients where they either might not have noticed or they were embarrassed to discuss that. And so oftentimes we'll defer that perianal exam from the clinic, and we'll just do that when they're under anesthesia at time of endoscopy, just for patient comfort. For all of our patients, we also do small bowel imaging. So our preference is MR enterography. And so he underwent his MRI, and they noted some small bowel thickening in the distal ileum, which was consistent with what we saw with the endoscopy as well as in the ascending colon. And then also some patchy areas of thickening in the jejunum. And they also noted that fistula on the exam. So this also coincides with what we were seeing with as far as like the general belly pain and some of the growth issues, particularly when kids have small bowel disease. We see that as well. And so he was diagnosed with ileocolonic and upper tract Crohn's disease, also had the small bowel involvement, and then the perianal disease. And so he was started on infliximab, standard induction dosing of 5 mg per kilogram per dose. And we also started him on low dose methotrexate, just as a combination therapy to help reduce immunogenicity with his infliximab, and hopes to prolong his drug durability. And because of the methotrexate, we also recommend supplementing with folic acid to prevent folic acid deficiency. And then when we saw him back at about a month later, he already had completed 2 infusions and had significant improvement with symptoms, started with increased appetite and improved weight and stuff as well at that point.
Great. So actually, let me pause there before we go on, because there have been some extra questions that have come in. Jen, I'll ask you a couple of quick ones, and then Jessica, I'll ask you one. So just a general question in pediatrics, Jen, do you see more Crohn's or ulcerative colitis?
So more Crohn's. So it's a little bit different compared to the adult side. So we typically will see about 3/4 of our patients that present will have Crohn's. So usually it's somewhere like that 2/3 to 3/4 will have Crohn's compared to UC.
Great. And then as far as a child who's losing weight, as far as weight gain, aside from treating the Crohn's, are there other things you do?
Absolutely. So for all of our patients at time of diagnosis, they also meet with a dietitian. And so our dietitian, most likely in his case, with the concerns of the weight, probably also recommended some supplementation with some like complete nutritional shakes.
Great. So you do supplement, at least in the short term. As you said, in his case, he actually started to have a good response after 2 doses of infliximab and methotrexate. Jessica, let me just ask one quick question, then we'll move on. As far as treatment, he was put on infliximab and methotrexate. He's 12 years old, but if you were to see, say, a teenager, maybe a little bit older, young adult, would that have been your treatment? Would you use something different? Kind of what are your thoughts?
Well, I think so. In this individual, he has already perianal disease, and he's being diagnosed under the age of 25. So he already has 2 predictors for aggressive or destructive disease. So I would certainly want to use the best, most aggressive medication that I can. So using the infliximab, I think, is very appropriate. That's a choice I would make in this disease presentation. Because he's a young male, they're using methotrexate, and so thiopurine is adjunctive. And I do, certainly when starting infliximab, I almost always use concurrent immunosuppression to kind of augment the response and prevent antibody formation.
Great. So kind of even in the adults, that's a reasonable option. Obviously, in adults, we'll get into maybe treatment where there are more options approved for adults, such as ustekinumab, vedolizumab, than maybe we have in the child. But Jen, let's go ahead. And I think this case, demonstrates a young adult patient. And what are your key points in pediatric IBD in general?
Mm-hmm. So I think it's important to keep in mind that pediatric patients can present with a wide range of symptoms. So sometimes they'll have the typical, belly pain, bloody stools, that sort of thing. But we also will see the issues with growth delays, weight loss, and sometimes just puberty delays. So sometimes they really have minimal GI symptoms. And so it's important to keep that on the differential, especially with Crohn's or small bowel Crohn's. And of course, our, detailed history and physical exam, our screening labs and stool studies, ruling out infectious studies, screening with like a fecal calprotectin as well to look for inflammatory markers, so oftentimes our patients will have that when getting referred to us, or we'll get that initially. All of our patients get upper and lower endoscopies as well as small bowel imaging, and most of those patients will get MR enterography to help reduce the radiation exposure compared to CT scans. And so for all of our patients, our goal is to induce and maintain remission as quickly as possible, and then and hopefully be able to continue that remission and drug durability long term. For our treatment strategies, of course, we want to relieve symptoms. First and foremost, our patients want to be feeling better, but we really also strive, especially on the pediatric side, to really optimize their growth with nutritional supplements as needed, and really keep a close eye on that, and overall just improving their quality of life and make sure that they're living great lives as kids and adolescents and all their activities and extracurriculars and in school.
So let's move on to a concept of family-centered care. So I think, in kids, it takes a whole team, a multidisciplinary approach. So talk to us about family-centered care and who is part of this pediatric team.
Yeah, absolutely. So, for family-centered care is something that is really integral in the pediatric population, and so that's where the patient and the parents or caregivers are really partnered with a multidisciplinary team to really provide optimal care for these patients. And so for our team, so we're a larger team and a larger care center, and so you can see kind of the list here it makes up most of our team, and so all of the patients will have their gastroenterologist. We have IBD nurse coordinators, a nurse practitioner that does annual IBD visits, as well as helps with some continuity, especially if they're admitted. So she'll round with the inpatient team, and she does some other great jobs on the team. We also have a social worker and dietitian and psychologists that meet with our patients at time of diagnosis, as well as just once a year as a multidisciplinary sort of check-in with the patients to cover health maintenance as well. I think one of the other, often overlooked and under-resourced areas is clinical pharmacists. Ours kind of also doubles as kind of a biologic sort of navigator and part of the prior auth team to really help with adherence and prior auth related issues around biologics, and is a tremendous resource for the patients and families, drug assistance programs, and for us kind of navigating that whole process. And then, of course, data is important. So, so we also have data and a QI coordinator that helps with our population management strategies and data tracking at our site.
Yeah, and one thing I want to just comment, because a couple of questions came in. A lot of our physicians and caregivers listening are in the community, and the question is always, how do you do all of this? And really, I see that there are a few ways. So obviously, if you're in a region that has a tertiary center, as Dr. Dotson's, that has this team referring and having them help. The other way that we're seeing a lot is now with the telemedicine and virtual medicine, we can actually see a patient, get our team plugged in, but really return the patient to the gastroenterologist closer to the patient's home, but then have this access to this medical home, this team through this virtual platform. So I think more and more we're seeing this almost hybrid model of this medical neighborhood that we're really creating. All right, I want to switch gears, and Jessica, I'm going to ask you, we're seeing this is a case of IBD in an underrepresented patient. And, are there differences in underrepresented patients? And you alluded to this change from just white patients getting these Crohn's and colitis. Talk to us a little bit about underrepresented patients in IBD.
Yeah, and I think we certainly have a growing bulk of data to understand this, but we certainly have far to go in fully understanding these trends and these differences. I think when we look at the differences, we need to understand, is this a difference in phenotype sometimes, or some of it is due to the disparities of care these patients are experiencing. But certainly, as we've talked about several times today, we do notice an increasing incidence in IBD. These patients are less likely to have a family history of IBD, so they're the first index case within their family. Interestingly, Hispanic and Asian patients currently are diagnosed tend to have ulcerative colitis more often than Crohn's disease. And I think it'll be interesting to see if this trend persists, because we know in countries like South Korea, where as they became more industrialized, they first saw a big uptick in ulcerative colitis and then later in Crohn's. So I think we have to keep our eyes out for these changes. And then we do see an increased utilization of emergency department for some of these groups and some of the recently published studies, even by Dr. Dotson.
Yeah, and I think one of the comments is that oftentimes access to care might be limited, resources might be limited, and I think we see a decrease in adherence sometimes to medications, not purposefully, just because of either lack of understanding or lack of access, which leads to more utilization, going to the ER, going to the hospital, this change in care. So, Jen, let me pivot back to you around quality measures in pediatric IBD. You talked about quality. So tell us some of this and some of the key measures.
Right. So, so it's certainly important that we address this in our pediatric population as well as on the adult side too, really in order to make sure we're optimizing care and providing the best care possible and getting the best outcomes for our patients. So, things as simple as, are they on the correct dose of medication, based on weight or, based on, phenotype. So for TPMT with 6-MP dosing, for example, or using therapeutic drug monitoring to make sure that we're optimizing their biologics. Also making sure that, they're getting appropriate lab testing at appropriate intervals. So also monitoring for complications of their disease, not just, anemia and inflammation markers, but, any signs of liver, kidney irritation related to their medications, their vitamin D status, those types of things as well. And then for our patients, we typically will see most of the patients that are on some sort of immunosuppression, and we see them roughly about every 3 to 4 months. And then if they are having any kind of issues or active disease, then we'll see them more often than that. Our, disease, phenotypes and extent, like we mentioned with Timothy's case, that's making sure all patients have a thorough diagnostic assessment and then reassessment of their disease at time, at 1 year after to reassess for mucosal healing and therapeutic response. All of our patients have their nutritional status checked at every visit as far as their, height, weight, BMI, and then they have regular check-ins with the dietitian as well to monitor that. Our, patients from a disease activity standpoint, are scored with the scoring indices that we use and like physician global assessment or the different other activity indices that we use. As well as looking at obviously in endoscopy and MRI reports, and then non-invasively, the calprotectins and lab monitoring as well. And for our patient population, of course, tracking corticosteroid-free remission rates is also something that's really important.
Right. So talk to us about what's important in the pediatric patient with IBD. And then once you answer that, let's go back to the case and kind of hear what happened to Timothy.
Right. So I think, most kids will say they just want to be normal, and so that's what we really strive for is, what's normal, getting rid of all these symptoms, having them participating in school and excelling and doing well, going on, play dates, being on their sports teams and sleepovers and different, sports activities, that sort of thing. And, making sure they do well, throughout school and college. We also work hand in hand with families and schools to make sure they have things in place, such as like 504 plans, which allows them to have special accommodations as far as unlimited bathroom privileges and access to water or snacks if needed, stop time for exams and other sorts of things to really make sure that they're set up for success academically. And then we also help them setting up some similar things related to college and prepping for college and what they're going to do with their medications and infusions and things like that. So that's another important time period for them.
Great. So let's go back to the case and tell us what happened next with Timothy.
Yeah, so we see him back in clinic, and we asked about his vaccines, and he hadn't received his flu shot yet this fall. He recently saw his eye doctor and had his annual exam, and so eyes looked great. No extraintestinal manifestations there. He also is planning to have his skin exam done by his pediatrician at his checkup next month. And then he's now had IBD at this time for about a year. So we'll talk a little bit more about that.
Great. And now let's go to a question. So you did a nice job with the checklist. So tell us, it's good for us to review kind of what's important in our patients. So let's now ask the audience, what information do they feel is missing from Timothy's chart So go ahead and vote now. What's missing? A, endoscopy, colonoscopy, B, CT scan, C, vaccination history, D, all of the above, or C, I'm not sure. So let's go ahead and vote and see what people think. All right, so vaccination history, and then kind of a close one behind that's all of the above. So Jen, I think we're going to move on, but I think this was good because you really drove home the idea that vaccinations are so important. The fact that he had missed his flu shot, now bringing him up to date is really, really important. So let's go to healthcare transition. So we're going to talk for a minute on healthcare transition. Jen, I'm going to hear from you first, and then Jessica, I'll take you through the differences between peds and adult. But Jen, tell us about healthcare transition.
Right. So sometimes transition can be a little bit confusing, where folks will confuse transfer, which is just the transfer of care from one provider to another, either from pediatric to adult or adult to adult, for example, where transition is really focusing on the process. And so this is really a purposeful, planned type of activities that we go through with our adolescents and young adults, trying to prepare them from moving from a child-centered care model and family care model to an adult-centered care model. And so the transition over time then is really getting them comfortable with their disease and management of their own disease, being able to take care of their chronic illness, and being able to do that independently on their own without just having mom or dad or their caregiver taking care of all those things for them.
Right. So Jessica, now let's look at the differences between pediatric and adults. And by the way, a lot of you are asking great questions. I think in the next little bit, you're going to get answers to those questions, but if not, at the end, we'll come back to those.
Yeah, and so basically, I'm acknowledging that these are gross generalizations. So there's going to be variation. But in general, there's two big differences between pediatric and adult medicine. Number one, who is the decision maker? So in pediatric care, we're looking to the family and the parents to make the final decisions on how the care is delivered. On the other hand, when the people move on to adult medicine, we look to the patient to make these decisions. The families are still involved often, but we look at the patient as the primary decision maker. Then there's a big difference in who's providing that care. In pediatrics, as we've been hearing about, it tends very often to be multidisciplinary. Most pediatric gastroenterologists are actually in academic centers. So it's fairly rare for a pediatric provider to be in a private practice. On the other hand, 80 to 85% of adult providers are actually private practitioners. So most of the time, the patient's moving from a kind of a concentrated academic center to a more private practice model. And there's a lot of differences in that sort of care.
Great. And then you mentioned, I think it's a great segue to the next point about transferring to adult GI care. So talk to us about some of the considerations there. And I think for the audience that's asking a lot of questions, I think this is a kind of a nice summary to some of your questions, which we'll come back to again.
So certainly, I think there's a wide range in when it's appropriate for a patient to be transferred to adult care. So some individuals are independent and ready to manage their own care when they're 17 or 18. Maybe they already are working, and that makes sense. On the other hand, some individuals later on, when they're done with college, ready to move on, is a better time. So it's going to vary by patient. I think it's always important when we're transferring these patients to make sure they understand what the benefits of transferring to adult care is. And adult practitioners, of course, we have things to offer that are needed by adult patients that pediatric patients don't necessarily have that need for. So for instance, these patients, they tend to be more longer term of disease. So they may be biologic experienced and need more options in terms of biologic therapy that we're more used to doing. They may have more complications of their disease, such as dysplasia. So we need to make sure we're providing that care dysplasia and then complications of therapy if they've been on them for long term. And then adults tend to have more need for reproductive health care, for healthy conception, and to prevent conception when it's not needed. So these are things that we can provide expertise to them. And I think as they transfer, they need to understand what we can offer for them. So it seems more appealing to make that change.
Right. And so, Jessica, I'm gonna bundle 3 questions that are coming across into one, because you just alluded to these, and then Jen will get back to you in just a second. So one of them is, do you find that while a 20-year-old may think that they're ready to make transitions and decisions because they aren't used to it, they have difficulties? What happens if you have a patient that reached adult status, but you feel that they're not ready to transition to adult care? And how do you deal with a family that's strongly against transferring child to adult care? So I guess if I summarize all of that, for patients that are kind of at the crux of transition and moving to adult care, but either they're stuck because they're not ready, or you don't feel they're ready, or the family doesn't, how do you deal with that? How do you address that?
So I think as an adult provider, it's very important that I have open lines of communication of my referring pediatrician. So I think that being able to get back with them and to reassure the family that I'm still in touch with that provider, and that, if they need to, and if, I think for transition as well, I often, no physician is perfect for all patients, right? So if a patient transition, goes to one adult provider and they're not comfortable, they're certainly welcome to check out another one, because it's going to be a long-term relationship. I think a lot of this framework is built up by my pediatric colleagues. So because the elements of disease knowledge, assumption of independence, that takes time. As Jennifer was saying, it's not just a one-time event, it's a gradual process. And so moving forward, they need to be provided with that information so they can build that foundation so they are ready to move on. On the other hand, just like a little bird jumping out of the nest, at some point it will have to happen. So we have to be trying. I think those of us that assume that do a lot of transitional care, we have to be ready to have our hands out and catch the bird if it's falling out of the nest, and be a little more attuned to them if they are missing appointments. If they start to be flaring, why is that? Are they missing medications? Try and delve into why that's happening.
All right. So the summary from tonight is the little bird has to jump out of the nest some point, but we're there to catch the bird. All right, let's move on. So Jen, tell us about concerns of transitioning care. I think this is a great segue.
Right. So a lot of our patients are nervous and anxious about that process. And I feel like sometimes our parents are a little bit more anxious about it, compared to the patients, where they have a lot of concerns because they're used to that multidisciplinary care model. They're used to a lot more of that hand holding and all those extra resources. And, you miss an appointment, I send a note to my nurse and my admin, and they call and reschedule. And, so what's going to happen? A lot of the parents are afraid that, if they're not there and we're not helping orchestrate that, they're going to miss their appointments and things are going to flare. They're going to run out of their meds, so they're really worried about their disease and their disease control. They're also worried about, their role, too, because it's a transition time for the parents, so there might be their students or their kiddos are graduating college, and that's a whole separate transition. But then they're used to coming to appointments with them, that sort of thing. And so, so having an adult office that is comfortable, as long as patient also agrees, is it okay to have the parent there as a backseat sort of fly on the wall just to be there? Sometimes the first couple appointments, that might be something that's helpful. But we try to do our best to prepare as well, especially if patients are diagnosed younger with us, where we have several more years, where we eventually work on those independent skills, where we direct more of those questions to the patients, have the patients, interact with us, and trying to be, hush mom and dad a little bit in the corner, like, oh, I want to hear from little Johnny here, and also doing part of our visits with the parents out in the waiting room, so it's just conducting those visits independently, and then maybe bringing them in towards the end of the visit if there's additional questions or things like that, so trying to prepare them during that process, because it is really anxiety provoking. And even though, they're 18 and technically adults, if you reflect back of what we were like when we were in college, and just overall just the development of kids at this age and young adults, they sometimes don't have the best decision-making process, and there's other types of priorities, and they still have that sense of invincibility, for example. And so sometimes it's just a little bit more, like I said, hand holding or that little bird, like Jessica mentioned.
Great. Well, so yeah, thank you for that flashback to college, by the way. So Jessica, let's go back to the case. Now, Timothy's 20. So talk about the transitioning to adult care.
Okay, so Timothy has come to establish with adult clinic. He's just transferred. And we are contacted because he starts to have flaring symptoms. So he's having some abdominal pain and losing some weight. In further discussion, we find that, in fact, he had to miss a few infusions, or he was late because he had a job. And he had decided to stop taking his methotrexate because he wasn't sure if that was really helping him out. So we had to kind of evaluate what was going on. And we found, unfortunately, that he had developed antibodies to infliximab and had unmeasurable levels. And then he'd become anemic again as CRP was elevated. So at this point, we need to have a discussion. And certainly this is difficult because, again, he's just established with a new physician. He may not trust. He doesn't really know them. And he was quite comfortable with the medicines he was on before. He felt they're working. And now he has to make some decisions with this new provider about what he should move on to. And so in this discussion, part of what I try and explore is kind of why the last treatment failed, because it really failed due to adherence, not a mechanism of action. And understand how he feels about treatments. For instance, some patients really don't want to do injections. On the other hand, maybe with his new job, if I could put him on an injectable, he's not going to be missing doses of his next medication. So part of this discussion has to be engendering his trust that I can help him choose a good medicine, because his old doctor had him on a good medicine and I put him on not such a good medicine. And then understanding what obstacles to care were there so we can try and do it better this time.
Great. So, and you actually, as we talk about shared decision medicine, and you kind of outlined this already nicely as far as what shared decision in terms of the patient, the healthcare provider, especially as the pediatric patient goes from childhood to adult, identifying the goals. But I want to move to the resources that we have available, and really maybe, Jessica, we can outline to the audience what is out there to help us in these kind of difficult discussions and as we talk to these patients, especially around shared decision.
I mean, so certainly I think that the more educated a patient is, a better self-advocate they can be. And often, I want to have that discussion with them, but I can refer them. And online, you'll see that there are some great resources that are oriented towards young adults from Crohn's and Colitis Foundation. NASPGHAN has a great checklist for transitional care needs, and then Improved Care Now as well. So these are good resources for providers. But I think for the patients themselves, often the Crohn's and Colitis Foundation has a lot of great things that they can access easily.
Right. And then also for the audience, just remember that these resources are going to be posted on the CMEO Gastroenterology Hub on the CMEO website. So you'll have access to them. So Jessica, let's kind of wrap it up, and let's talk about the issues to address during transition from adult care with all patients, some of the important aspects, and then I'll go through some SMART goals. And then Jessica and Jen, I'm going to ask you both kind of some specific treatment questions. I know we're right at 7:15. We'll probably run about 5 minutes over. So for the audience, feel free to send in your questions. But Jessica, talk to us about this transition to adult care.
I mean, I think the bottom line is we have to establish trust and communication so we can explore what obstacles there are to their care. And that includes medications, adherence to medications, identify mental health care needs, make sure we understand how great their health literacy is. Financial issues are critical. If we don't understand what their up against, then we'll just be frustrated if we don't, why aren't they adhering to the medication if they can't even get a hold of it? I think for all of the patients that we're talking about, limited clinical trial data for underrepresented patients needs to be addressed because we need to make sure we're providing the medications that are best for them, not for patients in general, and really identify social determinants of health.
Yeah, so as I look at the SMART goals, I want to thank Jennifer and Jessica for this wonderful program and overview. We will allow in a minute a couple minutes for questions, but I think the SMART goals for tonight are really recognizing the increased incidence of IBD in underrepresented patients, ensuring that pediatric patients with IBD do have this family-centered team-based approach, which you heard from both Jessica and Jennifer, and really then prepare our patients to transitional longitudinally, address their concerns, but also that of the family. I think you heard that from both Jen and Jessica, and then really integrating these checklists, which are very helpful. You saw some nice resource guides that Jessica outlined, and looking at regular assessments in this whole person, whole patient care. So just as a reminder, we'll try to get to a couple questions. If you want to ask a question, please click on the Ask Question tab, include the faculty member's name. We will run out of time, so we may not get to all your questions. And then also remember to visit the Gastroenterology Hub. This is a free resource and education to educate our healthcare providers and patients on IBD. And then just as a final reminder to receive CME and CE credit for today's program, please complete the post-test evaluation and you'll be able to download and print your certificate immediately upon completion. So before I say goodnight, Jen and Jessica, I did want to ask you one question about medicines and specific to medicines, because I saw some questions come in on Timothy. You know, he had done well with the infliximab, then he kind of started to miss doses. He developed antibodies. So Jen, maybe you first, although he's 20, you probably do still take care of 20-year-olds. What options does he have for treatment? And then Jessica, I'll ask you the same question.
Yeah, so in Timothy's case, since he had responded really well to infliximab, and then lost response just because of antibody formation. So he would be a patient that we would consider if he was open to it doing injectables and switching to like adalimumab. So that's probably the primary injectable that we use on the pediatric side, just because it has a pediatric label improvement for that. So that's usually our go-to, if that drug class is still working for them. And then if he especially with having the perianal disease, we know that the anti-TNF alpha inhibitors are the kind of the drug treatment of choice for the perianal disease. Additional options if he was open to, injectables would be Stelara, and we also use Entyvio if he wanted to continue to do like an infusion-based therapy. So that would be the options that we would probably discuss at the pediatric side.
Great. And then Jessica, if he saw you as that 20-year-old, what would you do, or what are your thoughts?
Well, again, I think if he was unlikely to be adherent to methotrexate or concurrent immunomodulator, then I might try and choose something that's a little bit less immunogenic. So then I would be going ustekinumab. And if he was missing, on the other hand, some individuals are very reluctant to give themselves shots. So if I thought that was an issue, then I'd be looking at Vedo. But I guess there's a number of thoughts going on here. But on the other hand, because the mechanism of action had been great for him, adalimumab would be a great option. But he'd have to agree. I know he makes antibodies, so we'd have to be like on the same page about the concurrent immune modulator if we made that choice together.
Yeah, and I think one important aspect of this case that you heard with the transition is that as the 12-year-old, Timothy had a family behind him, so probably taking him to infusions, making sure he was adherent. Now he's transitioning, he's 20, he's missing doses, and that's common. That's something we see all the time. So I think, Jessica, to your point, it's having that shared decision discussion saying, would you want to get infusions? Is there something that's advantageous, and maybe vedolizumab would be a good option? Or is this something that you're really not going to come in and you want to take less frequently? And then I think ustekinumab, which also has a systemic benefit as well. Both vedolizumab and ustekinumab, to your point, would not need combination, very low immunogenicity, very good safety profile with both of those as well. So for everybody out there that put questions in, I'm sorry we didn't get to all of them. We got to most of them, but I really want to thank both Dr. Dotson and Dr. Philpott for your experience, your education, the presentation. I know I always learn a lot from these. And to CME Outfitters, thank you for putting this program together. I wish everybody a good night. Stay safe, stay well.